So what I was hoping to do today was to give you all just a little bit of background about myself and some of my own personal history, give you a very brief overview of osteopathic medicine in the US, and talk about osteopathic tenets and philosophy, and then talk about for whom osteopathic medicine might be a right choice, and of course, give you guys some resources at the end for those of you who want to know more information. Click forward. So there's me, Brooklyn bred, born and raised in Bed-Stuy. I grew up in a single parent household, and I was lucky enough to get a scholarship to a boarding school in Massachusetts. From there, I went on to college at Barnard College, and I was a chemistry major for no other reason than because they made me pick a major, and I thought, why not? And then I got my master's at Teachers College at Columbia University to teach high school, which I did for a couple of years before going on to medical school. But part of the reason I got my master's was because I didn't know what I wanted to do. I came into college thinking I was pre-med, but when I started shadowing, what I saw was not what I thought medicine was. And I immediately said, this is not what I want to do. So I said, let me get my master's and sort of figure things out for a while. Next slide. So while I was there, that young woman who's under my head, I'm there to the top right of your screen, the woman underneath me, she was actually getting her degree in chiropractic medicine, and she was a math major at Barnard, and she was trying to convince me to become a chiropractor. And she said, this is how chiropractic medicine is different from allopathic medicine or MDs, and this is how it's different from osteopathic medicine or DOs. And when she was talking about osteopathic medicine, I said, wait, what's that osteopathic one? That sounds really interesting. And that's actually what set me on my course. Next slide. So really oversimplification of osteopathic medicine versus allopathic medicine. For both of them, you need to have a bachelor's degree, you need to have a 4-year degree from an accredited school, and you need to take your prerequisites in basic biology, organic chemistry, usually calculus and physics. You need to take your MCAT and then apply. For both of them, you can go into any specialty. So whether you're a DO or an MD, you can become a family physician, a cardiologist, an OB-GYN, a cardiothoracic surgeon, whatever it is you're interested in being, you can go into either specialty from either pathway. Both of them, whether you graduate from an osteopathic medical school or an allopathic medical school, both of them continue their training, which all physicians have to do through a residency program that is sponsored by the ACGME. So all residencies in the US go through one pathway, whether you go from an osteopathic medical school or an allopathic medical school. And so really the core difference is what is your base training and what do you want to have included in your undergraduate training. Next slide. So from my perspective, the thing that I found most interesting and that was most compelling was both the philosophy of osteopathic training as well as the additional training in osteopathic manipulative treatment. So all physicians get trained in how to do a history and physical diagnosis. All physicians get trained in how to write for and order appropriate diagnostic tests. But osteopathic physicians also get trained in the fundamentals of how do we diagnose with our hands, which means are we able to palpate on the musculoskeletal system and evaluate them in a much closer fashion to look for dysfunctions or malalignment of the skeletal systems or tissue texture changes that could be contributing or a result of their disease processes. We also learn how to treat with our hands. That doesn't mean that we treat everything with our hands, but it's one more tool in our toolbox. And that part was the most compelling. Philosophy as well as the treatment options that I had as an osteopathic physician. Next slide, please. So really, for me, it's about what your philosophy is. It's not about which one is better or worse. For me, osteopathic was a better choice, but it's really about wanting something that speaks to your heart and speaks to what your ultimate goals were. For me, I've been a vegetarian since I was 20. I used to be very athletic and very fit, but still think that preventative medicine is the most important. When I started looking into schools, it was osteopathic schools and their philosophy that spoke most to being in sync with the patient and to treating the patient as the ultimate decision maker for their treatment plan. And that's not to say that there aren't allopathic physicians who feel the same way. It's to say that when I looked at schools, it was osteopathic programs that explicitly said that piece, and that was most important to me. Next slide. So what are the tenets of osteopathic medicine? The first and foremost is that every person is made up of mind, body, and spirit. And what we look for is knowing that the body is capable of self-regulation and self-healing. When you think about all that your body is able to do on a daily basis, it's able to do that without someone supervising it, without someone telling it what to do, and is able to clear a lot of diseases on its own. And as we'll talk about in a moment, that concept really plays a lot into how we approach our patients and how we treat our patients as far as the way we train our students. And so it was a fundamental thought process of our founder, A.T. Still, that says the body is capable of self-regulation and self-healing, and we're here to help encourage that and give it an environment that makes it easiest for the body to do that. Along the same lines, it says that structure and function are interrelated, meaning everything is shaped the way it is, moves the way it does for a reason, and that when things aren't functioning correctly, it's because something's wrong with the structure. So what can we do on a macroscopic level or a microscopic level to help those structures so that the function improves and goes back to what was expected? And finally, that rational treatment is based on the first three. This is not magical thinking. This is basic biology and physiology and trying to do the most that we can to maximize what we know about the human body and human mind and human spirit. And so we're going to create a treatment plan that's based on all of those things. What that also means is that as a physician, I often have multiple treatment options that I can make available to patients. Based on evidence-based medicine, I'm going to give them what I think the best choice is for them, but based on what their goals are and what their circumstances are, what I might think of as their top treatment or best treatment might not actually be best for that particular patient. And so looking at what that patient's goals are, looking at what their spiritual needs are, their mental needs are, we might actually choose something different. And so the concept of rational treatment is saying we're going to look at all of those components to come up with a treatment plan. Next slide. So how did osteopathic medicine come into being? Next slide. We were actually founded by Andrew Taylor Still, who himself was the son of a physician. He was in fact trained to be a physician. His father was a physician and a pastor, and Andrew Taylor Still was a devout Christian. It was a lot of what promoted his thought process, and his deference to his spiritual work is a lot of what motivated him and said, this is how the body works and what we should be doing as physicians. Next slide. It's important to note that 19th century medicine does not look much at all like 21st century medicine in terms of training. Overwhelmingly, most physicians were trained by apprenticeship. And at the time that Andrew Taylor Still was originally practicing, most physicians didn't actually go to medical school. Medical school was considered a luxury for the rich. It was something that people did when they were in cities. And most physicians nationally actually worked under an apprenticeship until they were cleared to go and practice by the person who they were working underneath. And part of that experience for Andrew Taylor Still was looking at infectious disease and a major cause for death in his time. Next slide, please. One of his motivating factors, you can click forward, is that he lost his first wife and several of his children to meningitis. And when he looked at the treatment plans that were available, you have to remember this is 19th century medicine. A lot of what were considered interventions we would now consider direct poisons. So mercury, arsenic, things that made you sweat, things that made you vomit, things that caused diarrhea, all of these were the interventions of the time. Next slide, please. And that concept of doctors doing something was the concept of heroic medicine. So the person in that picture is Benjamin Rush. He is quote unquote the father of Western medicine. But it's also important to note that in 19th century America, there were multiple schools of treatment for patients, and heroic medicine, or what would later be deemed allopathic medicine, was just one of several schools of thought. So in that same time period, you had Graham medicine, which when you think of the graham cracker, it actually has roots in the concepts of not eating sugars or spices or really bland foods or things that would excite the spirit. It was the same time period as chiropractic medicine, homeopathic medicine, and osteopathic medicine. But heroic medicine, which was the dominant school of thought, really spoke to do something. And what A.T. Still saw from his own experience was that doing of something actually caused more harm than good. So he was actually looking for an alternative. He was a peer of David Palmer, who's the founder of chiropractic medicine, but he didn't believe that only manipulation was the way to treat. He really avoided pharmaceuticals, but he also believed in other interventions. And that was really sort of the dividing line between him and Palmer. Next slide. And as the story goes, there's lore to all of these stories, but as the story goes, A.T. still had a headache, and he put a rope across some branches to rest his head. And when he woke up, he didn't have a headache anymore. And he asked himself what was the cause to relieve his headache. And that sent him down the path to look at the musculoskeletal system and to say, everything that we are as human beings is divine and well thought out and designed. And so how can I help contribute to make that divine system maximally functional? And that's what he aspired to. Next slide, please. So he spent some time studying the musculoskeletal system and studying under various schools of thought, and then founded his first school in Kirksville. One of the things that's most outstanding about osteopathic medicine was that they were one of the first schools to admit women to their schools. And from Kirksville, the school spread. Next slide. Again, as I mentioned before, there were multiple schools of thought for how to treat patients, and all of them were vying at that time to treat patients and to be legitimized. And we had several famous people who were advocates for us, Mark Twain being one of them. One of the ways that they convinced legislation to fully license osteopathic physicians was by actually going out and treating politicians, so that when other practitioners said, oh, osteopathic medicine is quackery, this doesn't make any sense, osteopathic physicians were right there actually treating the politicians who could stand there and say, actually, I've had my family members treated by osteopathic physicians, and all of what you're saying is not true. Next slide. One of those famous people who helped to advocate for us was actually Teddy Roosevelt. And this was happening nationally to legitimize the osteopathic profession, so that by the 1960s, all osteopathic physicians were fully licensed, including in the military, nationally. Next slide. So again, the first tenet is that people are made up of mind, body, and spirit. And so what can we do as osteopathic physicians to help incorporate all those components as we treat and approach our patients? This becomes a little bit more challenging because of the format. Next slide, please, Brett. So we want to look at and examine the patient and look for malalignment of their skeletal system. We look for something called tissue texture changes. And what do I mean by that? So for example, if you sprain your ankle, it swells up, it puffs up. And so you get this swelling and this puffiness. It can be tender to touch. You can press on it and maybe see a depression there. That change in what the skin and the muscles feel like is called tissue texture changes. And there are different types of them. It's not just swelling. So one of the things that we look for are changes in the tissues to say, where are there obstructions? What could be causing this? And how do we alleviate things that get in the way of the body clearing its own infections and injuries, and increase arterial and venous flow to improve healing? Next slide. So again, structure and function are reciprocally interrelated. And so we're always looking to say, is the structure properly aligned? Is everything moving the way that it's supposed to be, so that the body can help heal itself and promote healing internally? Next slide. So we're going to come up with a treatment plan based on those first three slides. Next slide. So one of the cases that I wanted to put forward to you is the idea of a patient coming in who's pregnant, who has shortness of breath, and who's having an asthma attack. So this person's coming in and they're near the end of getting towards the end of their pregnancy in their second term, and they're using their inhaler a couple of times a week, and they're coming in with shortness of breath. Next slide. So when we look at the physical exam, everything in red is what's abnormal. So this person's respiratory rate, the RR, they're breathing a little bit faster. They have a heart murmur, that can be normal. They're breathing a little faster, they're wheezing. They're gravid just means that they're pregnant. Their diaphragm, what moves the air in and out of your lungs, isn't moving as well as you would expect it to be. Next slide. But they have, of course, some swelling in their legs, which can be common in pregnancy. But the section under biomechanical exam really speaks to how we document what we're able to find with our hands as osteopathic physicians. And so all that language, it doesn't really matter for the purpose of this conversation. All that language is saying that the person who examined her found things that weren't normal. The full range of motion of how our neck moved, of how our back moved, of how the muscles felt wasn't present. And so looking at things that the physician can do to help promote healing. It doesn't mean they're not going to write for prescription medications, but it's saying what else can we do besides adding more medications, especially in a pregnant patient. I'm sure Dr. Livingston can chime in, but often in pregnant patients, whatever their problems are, you give them Tylenol and tell them when their due date is, and you hope for the best. Unless the baby is critically in crisis or the mom is critically in crisis, there aren't a lot of things that you're able to do or offer them because so many things can jeopardize the health of the baby. And osteopathic manipulation is one of the things that you can do that doesn't interfere chemically with the baby and can help promote healing for the mom and for the baby. And this was the part that was so exciting for me as somebody who was applying. It's like, what else? I didn't just want to be a chiropractor. I knew that there were times, like if I'm having a heart attack, take me to the cath lab. I knew that there are times if I'm asthmatic, I might need an inhaler, but what else can I do to help promote healing? And for me, this was the exciting part of it. Next slide, please. It was being able to say that I can put my hands on this patient, find diagnoses, look for changes in the musculoskeletal system, look for changes that can reflect autonomic, parasympathetic, and sympathetic innervations that could affect the patient's respirations and help that patient to breathe better. Next slide. So in this particular patient, what this documentation is showing is that they have some dysfunction in their neck. And so in that first slide, the person's doing some soft tissue techniques, which is basically like if you think of a really specialized form of massage to help relax the tissues and help the vertebra go back into their normal position. It can help alleviate tension, which can also contribute to the patient's anxiety and how well they're breathing. Next slide. Additionally, we can do muscle energy techniques to the patient and twist and turn the patient to help stretch muscles out and have the patient push back against our resistance to help, again, normalize the tissues and help align the skeletal system. In the thoracic spine, all of our sympathetic innervations to our body come from our thoracic and upper lumbar spine. And so helping to normalize that alignment helps with the autonomic system. Next slide. We can also do high velocity techniques, and those are the cracking techniques that people often associate with manipulation. And so in this particular image, the person's doing a seated version of that, using the patient's body against the practitioner's chest to correct and realign the vertebral system. Next slide. So when we look at what we're able to do with this patient, we're still writing for prescription medications, but we can also do manual manipulation to help contribute to their care with the understanding that this particular patient, because they're pregnant, there's a limitation on other pain medications that I can offer them. There's limitations on some other medications I might be able to give them to help with respirations because they're pregnant. And so manipulation becomes a treatment option that contributes to their care. Next slide. So who should really be interested in osteopathic medicine? It's really about your philosophy. And again, this is not to pit one against the other. This is just really about saying what speaks to who you want to be as a physician. And for me, it was an environment that explicitly said, we want to help patients get better. We understand that just because we recommend something doesn't mean that that's what the patient's going to choose. So what are their priority for their goals as far as what they want to do with their care and helping to come up with a treatment plan that moves towards that. Because we get this additional training, particularly in the first and second year, but it carries on to third year, but especially in first and second year where the students are in lab every week learning these things. That means they're getting reinforcements of the anatomical structures and musculoskeletal system. So anyone who's interested in things like orthopedics or physical medicine rehab or sports medicine, because of that additional training, you're just more adept with the musculoskeletal system. It's just because it's more of the focus of what we're doing. Anyone who's interested in OB-GYN, because again, there's so many limitations of some of the things that you can do for patients in pain. I've never seen a pregnant patient that didn't have some sort of neck pain, upper back pain, low back pain, etc. And again, besides Tylenol, there's not a lot that you can offer those patients. And so again, it doesn't mean that you're not going to do surgeries. It doesn't mean that you're not going to do other interventions, but it does mean that you have this extra thing that you can offer to your patients. Anyone interested in international or global health, treating the underserved. The insurance company might not cover the medications I want to write for. The patient might not have insurance at all. I might be in a rural environment where I might have a cap on what I have available to me. And so being able to treat with my hands, buffers a little bit of that gap of resources that can sometimes be limited depending on where you're practicing. And so I think there's a wide spread of people for whom osteopathic medicine is something that should really be considered depending on what your end goal is of where you want to practice and how you want to practice in the world. Next slide. So I had to keep a running count. I had to double check this number because it keeps changing. When I applied to medical school, there were 17 osteopathic medical schools in the country, and now there's 37. I think it says at 58 locations, and we represent 25% of all medical students in the US, so we are a substantial minority. Next slide. So I would ask Brett, just because he has access to it, to copy and paste those links into the chats for people who want to have access to them. Some of the links that I have there, no, don't fast forward yet. Some of the links that I have there, we have a demo from Rowan SOM. It gives another long explanation about osteopathic medicine, but just to save you time, if you just want to see the demo, you can scoot ahead, I think about the 45-minute mark to see a demo of osteopathic manipulation by one of our students. There's also a link to ACOM to look up osteopathic schools in the country and to learn more about osteopathic medicine. All of our students are required to read the DOs in America by Norman Gevitz, which gives a much more detailed history of osteopathic medicine. And I think it's important if you choose to go this route to know what you're signing up for, know what it is and what it isn't, so that you can speak intelligently and make a choice that's going to affect the next 40 years of your practice. Next slide, please. So for me personally, after I graduated from Columbia, I went on to PCOM, Philadelphia College of Osteopathic Medicine. I became board certified in family medicine and did an additional fellowship in osteopathic manipulative medicine. And then I got my fellowship, which is another degree after that, in the American Academy of Osteopathy. Next slide. You're gonna have to click forward. I was very lucky during my training. I got recruited into academic medicine. There are lots of routes, no matter what specialty that you're thinking about going into, whether it's family medicine or OB-GYN or pediatrics or sports medicine, there are lots of options of what you can do in practice. I got recruited into academic medicine and I've never looked back. I've really enjoyed teaching medical students. I've been a residency director and trained residents. That led to me writing a book on osteopathic manipulation, which has been translated into Chinese and Japanese. And I've been invited globally. I've lectured in Germany, in Kenya, and in China on osteopathic manipulation. And it's just been a whirlwind and a lot of fun. So I really hope the best for you. Next slide. And any questions that you may have. I think it's really important for you to figure out who you are and who you want to be, and what program, not just allopathic, but osteopathic, but individual schools are going to help you be the best version of yourself. Thank you.
Dr. Channell, Millicent, thank you so much. Now you guys see why I invited her. Oh my goodness. So if anybody were to get their hands on the Philadelphia College of Osteopathic Medicine 2001 yearbook, in it says, and then there were two. And we were looking at the two. We started off with 4 African-American females, and unfortunately different things happen with the other two very intelligent women. But Millicent and I were the last two standing from a Black woman perspective, and we held each other up. This woman here held me up. I'm telling you, medical school was very challenging, but to do it along somebody with this level of dedication and intelligence, I only wish that other people can have that type of relationship. And so I hope that all 18 of you have gathered some useful information from Dr. Channell. And please, let's engage, let's dialogue, and make her feel welcomed. And then we have Tori, who is, thebomb.com as well. So I can't wait to hear from her. Anybody want to start some dialogue? Tori, feel free. Let's go for it.
So I know that this is supposed to be about, allopathic and osteopathic. So I don't want to because the presentation, which thank you, Dr. Channell, was very thorough and representative of the field. Again, my name is Tori. I'm not a third year. I am a medical student at the Philadelphia College of Osteopathic Medicine. I am, again, for those who came a little bit later, doing research here between third and fourth year. I chose, that's a great question. I do want to answer that, having done both. And I don't know, Renee, if you did both, but I'll speak a little bit to it. And you are actually more close to the more recent. I did the older application, and the older MCAT, so I can talk about my experience a little bit. I would say that they're both pretty when in terms of you put your information into a larger portal, and then you take that larger portal with your MCAT score, your transcripts, your letters of recommendation, your personal statement, so on and so forth, and all of that gets uploaded into the system. It gets verified. Both systems for MD and DO have that. Then from there, you send it out to specific schools who may have extra things that they want you to kind of include in your application. From there, you will either not get a secondary application, or you will, based on what their, base level requirements are. And you're supposed to turn around and send those off. I don't know, maybe Renee, you can speak to this a little bit more about the cost differences, but it was all expensive to me. Meaning, I think the first initial application when I did it was $240 or something like that. And then meaning to submit the whole portal. And that's for both of them. Both of them have that kind of 200 something cost. And then to submit to each individual school was $35 at the time, but I'm sure that that's gone up. Yeah, I see Renee shaking her head. And then the secondaries can be anywhere from $50 to $100 and some odd dollars. And say you get to the secondary process, you submit your secondary, you get an interview invite, and you've been offered admissions. Then there are even, I don't know what you even call it, deposits that you would have to pay to keep your seat. So it's a very expensive process both ways. I can't think of many differences. The biggest difference was that most schools for DOs wanted you to have shadowed a DO physician, and no matter in what field, but just have that experience and then get a corresponding letter of recommendation that gives you a huge leg up. I wouldn't even, from my perspective, apply without that in hand and tow, because it's paramount, like Dr. Channell was saying, to understand what the tenets are and what DOs are about.
I'm pretty sure that there are some waivers for some of that, for some of the application process, I think, particularly for the secondaries. And so I just want people to have that on their radar, is to look for waivers if you have any financial hardship, which can alleviate some of that, I believe. At least that used to be some of the case. Renee?
Yeah, actually, it's more so for primary, if I'm not mistaken. There might be some for secondaries, but it's also quite hard to get in some cases. I certainly didn't qualify, even though I was struggling to pay for my application. So yeah.
Renee, you had a comment?
Yeah, just to agree with everything that was said, there are two different portals. So for MD application, use AMCAS, and for DO application, COMAS. I did both. They are both expensive, and I believe some schools, if you ask them, they may give you a fee waiver if you were pre-approved for the AMCAS or COMAS application. And also, I guess one small difference between the DO and MD is for the DO personal statement, a lot of schools want you to specify why you want to be a DO in your essay. I use the same one, but I mean, if you feel like you have something extra to add, then I would definitely add that in there to your DO application. I know that you should shadow a DO. I absolutely recommend that. I also did not do that until my application cycle. So I did not shadow a DO until after I applied, which I don't think it made too much of a difference, but it is something that you should definitely do before you apply to both schools.
Looks like we have a question here. What is your recommendation on going about the challenge of being with people who question osteopathic medicine and practitioners and think that only doctors with MD title are more legit? Dr. Channell, I'll let you answer that, and then I can give a little bit of a response as well.
Sure. I think that's a pretty antiquated way of looking at the world. And one of the reasons I encourage people, it's a little bit of a dry read, but one of the reasons I encourage people to read the DOs in America is it really gives you a decade by decade play on the competition. These were two groups of people in competition for the same patient population. And so there was a lot of denigration going back and forth between them. I think that if you look today, a lot of what was there, even when Dr. Livingston and I trained, just doesn't exist in the same way. I think there are certain corners where it's more prevalent than others. But I don't think that it exists in the same way that it did even a generation ago, let alone 2 generations ago. So I think it depends on who you're talking about. And I also think that's why it's so important to know why you're doing what you're doing to defend it. When I was a student, I did my last 2 months of clerkships in Kenya. And I was at a site that had people from all over the world coming. And there was an MD orthopedic surgeon that was there. And it just so happened, just for kicks and giggles, that the presentation was on low back pain. And my preceptor, who didn't know anything about osteopathic medicine, said, well, student Dr. King, why don't you tell us more about, osteopathic medicine? And I gave my spiel, and I got a lot of pushback from the orthopedic surgeon. And we actually went toe to toe when I was asked to come back and do a presentation on osteopathic medicine. And by the time I was done, he publicly said, you're going to be a great doctor. Like, you defended what you had to defend. You were rational. You were clear. You brought your resources. And, didn't apologize because he's an orthopedic surgeon, but apologized as much as an orthopedic surgeon is never going to apologize to anybody. And so I think it's really important for you to know why you're doing what you're doing. I only applied osteopathic. Other people go osteopathic because their primary doctor was an osteopathic physician, and they were so inspired by how that one person treated them. They wanted a similar training path, or they want to stay local to their community because we're known for being in underserved and rural areas. And so they want to train in the community they're ultimately going to practice in. There's lots of reasons to go to an osteopathic school. And so you just really have to know why. I think that bigotry is still present, but it's so much smaller and less than it was even a generation ago. And I'm sorry, Dr. Livingston, I meant us as a generation ago, even a generation ago, it's so much less prevalent, especially now that we have a single residency application process. And so between 2015 and 2020, we had 2 residency programs tracks for osteopathic and allopathic, and they merged. And we already had a lot of our students going into allopathic residency programs. Dr. Livingston trained in an ACGME approved program when she came through. But now all of our students go through that. And so that separation is really gone. And I compare it to, and allopathic physicians can go to programs in residency and get training in osteopathic manipulation as part of their training now with that merger. And so people say, well, why would I choose osteopathic? And I say it's a difference between a chocolate cupcake and a vanilla cupcake with chocolate icing on top. You know, what do you want your experience to be? Who do you want to be? They're two different things. And so I'm going to stop talking now. I can go on forever on this.
No, that was an excellent response. I hope that students were able to get some perspective. I agree. It's a fairly antiquated question, and I'm obviously going to borrow that phrase because that's exactly how I feel. You know, as a OBGYN physician here in Lancaster, you're exactly right. Patients care and they don't care about you being an MDDO. What they care about is, are you good? Do you listen to me? Do you know what you're doing? Are you practicing safely? Are you a safe doctor? And the last time I looked, patients will follow their doctor. You could practice at hospital X, Y, or Z. If Dr. Livingston and Dr. Channell are going to hospital X, Y, or Z, they're going to go to that location. So the key is to, because I want to make sure that the question gets answered, which it has, and then some with Dr. Channell's answer. When somebody either makes you feel that way or asks you that question, most of that type of mentality is from lack of knowledge. So before becoming somewhat defensive or assuming the negative, just explain. Oh, well, you know, here is a DO. Start with DO first. Here's what a DO is. Here's what an MD is. Focus on the positives of both of them, and the question and maybe the negativity that's trying to come along with it will quickly dissipate because you're not giving any life to it, and just you speaking intelligently and giving a background will likely help people value both MDs and DOs.
Yeah, just to emphasize what was said in the chat by Tori. I worked at a health center where there were MDs, DOs, PAs, and NPs, and patients did not really care at all. In fact, they just called everyone doctor who they were seeing because they didn't really know the difference. They just care that you are able to have a relationship with them and provide good care, which everyone and all of the healthcare professionals, whether they're doctors or practitioners, the difference. So I see that. Sorry, go ahead.
I'm sorry, Renee. Finish, Renee. I'm sorry.
Oh, I was just gonna move on to another question, but. So I see that someone asked, what are the reasons why I like MD or DO schools, and how did I know which one was the right fit for me? So I did apply to both. I initially shadowed at my school, Franklin and Marshall. They have a preceptorship program in the family residency department, and in that program, I was able to see both MD. And I asked them a lot of questions regarding the differences because I had no idea what the difference was. And from shadowing them, I didn't really see much of a difference. It's just two kind of different letters. So after that, I also attended the SNMA annual medical education conference, and they had a session on allopathic medicine. And I was able to gain more knowledge about OMM and what osteopathic medicine was. So I decided to apply to both. Now, when it came to accepting a medical school, I was actually between PCU and my school. And I didn't really pay attention to whether it was MD versus DO because I found that a lot of the ideals that were emphasized by my school involved looking at the whole patient and this the idea of holistic care, which was traditionally in osteopathic schools, and I think my school just offered me more opportunities that would fit me better than the other school would.
I just want to also add, because I saw a question and it said, you know, someone's had a strong interest in osteopathic field, feel as though patients and the people in general don't know about the field and only give credit to MDs. Yeah, that's a thing. We're crappy about our publicity. And I was really frustrated with that when I was a medical student, feeling like I was always explaining myself. I actually don't practice family practice anymore. I only practice osteopathic manipulation. I'm in a neuromusculoskeletal institute at our school. And I gotta tell you, my waiting list is really long, and the waiting list for our OMM doctors is really long because so few people do what we do. And our patients, we get so much referral from word of mouth. By the time you're actually in practice and figure out your particular pathway, it will or it won't make a difference. I'm a specialist in OMM. It doesn't make a difference in my life because everybody in my life and all of my patients are clear about what I do, or at least they're clear about the effects. Because some of my patients will say, I don't know, she does this thing, I go in, I feel like crap, it hurts for a second, and I feel a lot better. And they don't necessarily know the details of what it is, but they come in and they know that I'm an osteopathic physician. That part they do know. And then when they go other places, they look for osteopathic physicians if they move out of state, or I get patients who are referred to me or look for me because they've moved from one state to another and they're looking for another osteopathic physician. And so while I think collectively as a profession, we could do better, in practice, whether you utilize OMM or don't utilize OMM, in practice, I don't think it ultimately is a deterrent to your practice. I also want to say, I'm a curriculum dean, and my boss is a senior associate dean for academics. And she also trained, she's a DO, but she also trained at an ACGME residency program for family practice. And she said something that has always stuck with me for several years, which is she didn't really see a difference between DOs and MDs in primary care. They're all holistic. They all kind of have the same kind of philosophy in terms of how they practice. The people who are attracted to primary care are all sort of on the same page. Where she saw the difference was between MD cardiologists and DO cardiologists. That she felt that when you were looking at specialists and surgeons, that the ones who in osteopathic training tended to think more like primary care doctors in terms of thinking more holistically. And she saw that drop off more precipitously in the MD specialists. And I've paid more attention to it now that I have more exposure and contact with MDs who aren't in our system. I don't count the MDs in my system because we outnumber them and so we influence them. But looking at MDs who are in systems that are predominantly allopathic, I see the difference in the specialist. I don't see it in the geriatrician, but I see it in the nephrologist. I don't see it in the pediatrician, but I see it in the oncologist and how they approach their patients. And I think that that's part of what has to be considered as well.
Millicent, when you talk about that difference that she was describing, is she saying that in a positive to the osteopathic physician or the, yeah,
she's saying that the cardiologist, she gave an example and she went through this case and she gave the example, because you have, in any medical group, you can have DOs and MDs, right? And they're swapping off who's rotating on the patients in the hospital. So she's on rotation for a month and she's rotating with MDs and DOs from the same cardiac group, seeing the same patients, and she's watching the interactions, and she's saying, well, the DOs lingered a little bit more, they talk more to the patient, they pause more to say, do you understand what I'm saying? They pause more on discharge to say, do you have access to what I'm recommending? They were just more concerned about, sort of the details, more like a primary care doctor would be in terms of making sure that those bridges were crossed. You can come up with the right diagnosis, but if you're not making sure your patient has access, if you're not making sure that your patient understands what you're saying, if you're not making sure that they're on board, that these are the patient's goals, sorry.
This is the preaching I was used to hear, and I'm like, oh,
that's the difference. And so MD cardiologists, DO cardiologists, they're going to take the same boards, they're going to do great, et cetera. They can diagnose you correctly. But, who's the oncologist that's going to walk in and say, yes, Mrs. Smith, you have cancer, and walk back out? And Mrs. Smith is spiraling and still in shock and feeling like her ears just got blown out. And who's going to sit there for a minute and be like, why don't you sit with this? I'm gonna see some other patients. I'm gonna come back. And we're gonna talk a little bit more. Or if they're not gonna do it themselves, make sure the nurse practitioners, are you watching this? Because Mrs. Smith looks like she's spinning a little bit, and we might need to just spend a little bit more time with her or set some time aside. And that's the difference. It's really just, it's hard for me to talk about this because I often feel like I'm bashing MDs, and I'm really not trying to. It's really just trying to say, you know, what statistically is more likely to get you to where you want to be. And the reality is that there are some circles and some circles and some circumstances where being an MD is going to make your path a little bit easier just because they're the majority of practitioners, period. That's the reality. That's why I say you have to kind of really know why you're in it and know what you want in life beyond this whole medicine thing. If you're always just chasing prestige, and what everybody approves of isn't necessarily what gets you happiness. It isn't necessarily what makes you your best version of yourself. So you really, really, really need to understand your why and follow your why. The what will all fall into place if you understand your why. So for me, my why was crystal clear, that I wanted to be a guide to my patients, and I understood that their health was their responsibility, and I'm here as an incredibly educated guide to help them make better choices, but the choices ultimately are theirs. That's my personal philosophy, and osteopathic medicine spoke to that for me. Everybody has to understand their why and what they're doing, whether it's MDDO, whether it's PCOM or Owens, whether it's Vanderbilt or UPenn. It's about the path, and then it's about the individual schools underneath them, about what speaks to you, about why you're choosing what you're choosing.
Can I speak to it from a student perspective?
Sure.
Because I definitely have had, I mean, people, even before I went to medical school, I remember I took a trip and I've had, you know, many positive experiences, but I just want to, as antiquated a question as it is, it still happens and people still question it. And I was, like you said, Dr. Livingston, before, I was definitely one of those people who was like, it's all the same, like get defensive. But then I realized, like, I don't need to be defensive. Like, this is, I'm going to be a physician just like any other physician, and it is what it is. And this is what we do. That's slightly different. And so one experience I had was with a woman, speaking of cardiology, actually, her father was some sort of advanced cardiologist. And she was like, well, what's this? What's osteopathy? What's osteopathic medicine? And so I was explaining to her, you know, the difference of how we get the training that Dr. Channell talked about. And she goes, oh, well, and I said, well, what kind of medicine does your father practice? And she told me he's an advanced cardiologist of some kind. And I said, oh, well, that's cool. And I don't remember exactly what was said, but with her next response was, oh, well, no, my dad's like a real doctor. And at that point, I just had to kind of collect myself, because I didn't know how to respond to that after having explained. And I was like, did I not do a thorough enough explanation, or did I leave something out? So I kind of just didn't, you know, move past that, because at that point it became maybe like a fruitless conversation. The other thing I will say, and I can't say that I had one experience that I've spoken about before with the Patients Are Waiting group, and that has to do with, you know, on my third-year rotations, during my surgery rotation, there was a particular resident who, it would be me, the PCOM student, and then another Jefferson student. And this particular resident, and this could have been for a multitude of reasons. However, he later expressed, without me even asking about it, that let me give a little bit more background. He would always choose the Jefferson student to work with and would always shoot me away to a different resident or intern. And so I wondered to myself why that is. You know, it could be because I'm, you know, Black. It could be because I'm a woman. It could be because I'm a DO student, a multitude of reasons. However, later when he pulled me to the side to talk to me about something, he goes, I know that you think that I picked the Jefferson student over, you know, you, the PCOM student. I was like, I never even said that to anyone, voiced that to anyone. So that was his own guilty conscience. And so definitely there still are people who are of this antiquated mind, thinking that DOs are better than MDs. Excuse me, and that MDs are better than DOs. But it's just, I don't know. I've definitely had more positive experiences than negative. However, it still happens. That's all I wanted to contribute to that. And even at me as a medical,
I do want to add one last thing to that, though. That sort of hierarchy, That's a really common cultural thing in allopathic schools. The UPenn person looks down on the Jefferson person, who looks down on the Temple person, looks down on the Drexel person. Like that sort of like, how do we shift and line ourselves up in hierarchy is culturally different. It's sort of like, if you go somewhere, because we're a minority, if you go somewhere and you are at a conference and someone says they're a DO, you're like, oh, where'd you go to school? It's like finding out you're in a frat or a sorority. Oh, what sorority? What? Oh, you went to an HBCU? Oh, what HBCU? Like there's an instant connection that you have there based around that. And so that desire to like say, here's the hierarchy and where are you on the hierarchy goes well beyond whether you're at an osteopathic school or an allopathic school. It's more global than that. So I want to point that out as well.
Any other comments before we close the session here?
Yeah, I just have one more thing to add. So regarding it to the like difference in, I guess, education that you would have, I don't think there is one, because at my school, I get taught by both DOs. And I know that at other schools, you get taught by both MDs and DOs. So on that aspect, there isn't too much of a difference other than the OMM, which is something extra that you're getting with the DO degree rather than an MD.
Okay.
And I think on that piece, you have to really look at individual schools as well to see what you have access to. And that's a deeper conversation as well.
Well, thanks everybody for chiming into this wonderful dialogue about DOs and MDs. And Dr. Channell, congratulations on the wedding.
Thanks.
Your beautiful bride. And
Thank you.
everybody. Feel free to join in the next session.
Thank you, guys.